All right, let's jump right into this explainer. In acute medicine, you already know the golden rule. Time is tissue. When a patient rolls in looking highly distressed, they're throwing off a massive flurry of symptoms. Some of those are true, actionable signals pointing right to the crisis. But a lot of it, it's just distracting noise. Filtering out that noise is literally the difference between saving a life and a catastrophic outcome. So, based on our source material, we're going to act as clinical detectives today and break down 3 high-stakes anatomical battlegrounds to see exactly how this is done. Here is our rapid-fire game plan. First, the anatomical airway gate. Second, the scrotal dividing line. Third, tissue pressure traps. And finally, execution and management. Okay, let's kick things off with Section 1, the anatomical airway gate, where we pit Ludwig's angina against deep space abscesses. Picture this. You're in the clinical hot seat. A patient presents with a muffled voice, a high fever, and they're drooling. Now, what's the trap here? It's recognizing that a muffled voice is pure noise. It's a shared symptom that pops up in multiple life-threatening emergencies, from retropharyngeal abscesses to Ludwig's angina. You need the specific anatomical signal to know if you should be reaching for a scalpel, a fiber optic scope, or antibiotics. The crucial tipping point is contrasting the physical presentations. Ludwig's angina is this rapidly spreading, bilateral cellulitis of the submandibular space. The true signal you're looking for? A woody edema and an elevation of the floor of the mouth that basically creates this crazy double tongue appearance, pushing everything up and back. Compare that to a peritonsillar abscess, where the signal is starkly unilateral. You'll see tonsillar enlargement and a uvula that's physically shoved away from the affected side. Anatomy completely dictates your action here. When you're looking at a lateral neck X-ray to evaluate for a deep space infection, the signal is incredibly precise. If that soft tissue plane exceeds 50% of the width of the corresponding vertebral body, boom, you found the culprit. It's an abscess, localized right between the pharyngeal constrictors and the prevertebral fascia. And listen, here is a massive, dumb mistake you never want to make. Attempting a blind oral intubation in a patient with Ludwig's. The anatomy is so distorted, direct laryngoscopy is practically impossible, and you'll just precipitate total airway occlusion. You need an awake fiber optic intubation or an emergent surgical airway. So, to quickly recap the pathognomonic signals for a peritonsillar abscess, if you hear that muffled hot potato voice, see trismus or lockjaw, and spot unilateral swelling with a displaced uvula, your execution path is clear. You localize it, usually with an intraoral ultrasound, and manage it definitively with incision, drainage, and antibiotics. Decisive action, no waiting around. Moving right along to Section 2, the scrotal dividing line, testicular torsion versus epididymitis. There's a really dangerous execution gap we see a lot, blindly relying on imaging instead of a good old-fashioned physical exam. A young guy comes in with sudden, absolute 10 out of 10 scrotal pain. What is your immediate reflex? Literally. Because if you're just sitting there waiting for a Doppler ultrasound, you are losing precious time. Intermittent torsion can actually show totally normal blood flow on a scan, which is a massive trap. It all comes down to a vital binary framing. With testicular torsion, which is a physical, mechanical twisting of the spermatic cord, the definitive signal is an absent cremasteric reflex. With epididymitis, that reflex is perfectly preserved. If that reflex is gone, the source material points heavily toward a mechanical torsion, not just a simple bacterial infection. And then you have the Pren sign. Simply elevate the affected testis. Does the pain magically get better? If it does, that's a positive sign pointing toward epididymitis. If he's still in agony, you're likely looking at torsion. This basic foundational bedside maneuver is your primary diagnostic tool before advanced imaging is even a thought in your head. Check out this timeline because it really hammers home that time is tissue mantra. From the sudden onset of pain at hour 0, you've got a critical window of less than 6 hours for immediate surgical salvage. If you delay past that 6-hour mark, the risk of total testicular infarction skyrockets exponentially. All right, Section 3, tissue pressure traps. We're talking compartment syndrome and strangulated hernias. Okay, a patient takes a nasty hit to a limb. The skin might look fine, barely bruised, but they are screaming in pain, completely out of proportion to the visible surface trauma. This challenges us to look past what seems like a benign surface injury and calculate the unseen kinetic disaster happening underneath, the pressure that's actively choking off the limb's blood supply. The true signal here isn't visual, it's mathematical. It's the delta pressure. You take the diastolic blood pressure and subtract the directly measured compartment pressure. If that result is 30 millimeters of mercury or less, that is a positive diagnosis for compartment syndrome. It's black and white. That number is your absolute trigger for an immediate fasciotomy. We see an incredibly similar pressure trap happen in the abdomen. A benign hernia is usually just an easily reducible bulge, but an incarcerated or strangulated hernia, that's a closed-loop pressure trap. You're looking for signals like an irreducible mass, severe pain, reactive erythema, and leukocytosis. It rapidly transforms into a ticking time bomb for necrotic bowel and systemic shock if you don't catch it. Which brings us nicely to our final section, execution and management, and the deadly wait-and-see fallacy. Read this quote from the source material because it is the ultimate executional pearl. An incarcerated or strangulated hernia represents a surgical emergency. Attempting to just push it back in or opting for a wait-and-see approach while you send them off for advanced CT imaging is a fatal technical error. The risk of sepsis from dead bowel is way too high. Immediate surgical exploration is literally the only right move.
Let's pull everything together into your clinical toolkit. First, audit the airway. Know the difference between a displaced uvula and a bilateral double tongue swelling. Second, test those scrotal reflexes at the bedside before you blindly order an ultrasound. Third, do the delta pressure math for limb injuries. And finally, never ever delay the OR for a strangulated hernia. Cement these into your brain to separate the clinical truths from the diagnostic noise.
I'm going to leave you with a question to chew on. In an era where we can order a high-resolution CT or a Doppler with a single click, are we slowly losing the life-saving art of the basic bedside physical exam? Because when time is tissue, knowing how to interpret a cremasteric reflex or calculate a delta pressure on the fly is almost always faster and sometimes more accurate than waiting on a machine. I highly encourage you to dive into the source material to explore this even more. Thanks so much for joining me on this explainer. I'll catch you next time.